On the antiretrovirals, yesterday we looked at those drugs that you can use, especially for the influenza viruses. We looked at those which bind the M2 receptors, the amantadine and the rimantadine. We also looked at those that block the neuraminidase enzyme, and all these drugs we were saying they are targeting sites, or they are targeting receptors within the virus. They are targeting receptors within the virus and therefore blocking the virus from binding its respective site, blocking the virus from binding its respective site. Like we did mention, the neuraminidase inhibitors will bind the neuraminidase enzyme, which is within the virus, and therefore the virus will not be able to bind its site within the sialic acid, which is within the host membrane. And once it doesn't bind, therefore, then the neuraminidase enzyme, will not be able to cleave. The virus will bind the sialic acid, but it will not be able to cleave. It will not be able to cleave, and therefore the drug will bind the neuraminidase enzyme, and we do know the neuraminidase enzyme is important in cleaving the virus from the virus, the glycoprotein of the virus, that is the hemagglutinin, from cleaving it from the host, and therefore once the neuraminidase enzyme is blocked, it will not be able to do that cleaving, because it will not have the ability to bind the sialic acid, cannot bring about the cleaving, and therefore the virus will not undergo what we mentioned yesterday as the endocytosis. It will not be able to get in, it will not be able to get out. So when we look at the drugs we have been looking at, have been targeting the viral receptors, the viral enzymes. But we do also have other drugs now which target not the virus, but they target the host. So we are going to look at drugs that target the host. So they bind receptors within the host. And ultimately, the effect is the same. Because once they bind the receptors within the host, it means now the virus again cannot bind its receptors within the host because they are blocked. But of course, the mechanism is slightly different, because we have said for most of the other drugs we have looked at, they bind the virus, they bind the viral enzymes, they bind the viral receptors, and now block either the virus from binding the host, or, as we have said, block the cleavage, as we have said, and therefore the development or the multiplication, the replication, the translation, all that is actually blocked. So now we want to start with the HIV entry into the host, because the other viruses we were looking at was influenza A, influenza B. Now we want to look at the HIV entry into the host, and we will look at drugs that have been used to block the entry, or what we call the fusion inhibitors. So HIV entry into the host cell. The entry of HIV into a cell is a complex process that involves several specific membrane protein interactions. Again, remember the membrane proteins are the receptors within the membranes. We have one viral glycoprotein, which we call the GP120, and it is said that it mediates the virus attachment by its binding to at least two host membrane receptors. So this is a viral glycoprotein, GP120, and it is able to bind either the CD4 or it is able to bind the C-chemokine core receptor, which we call C-chemokine receptor 5. So it can either bind CD4 or it can bind chemokine core receptor, or CCR5. There's bivalent interaction, that is an interaction with CD4, the interaction with the CCR5 induces a conformational change in the viral fusion protein GP41. So GP41, I believe, is also is a part of the glycoprotein, a part of the bigger glycoprotein, and this GP41 is the one which is responsible for fusion. Glycoprotein 41 is what is responsible for the fusion. The protein GP41 acts as the anchor for GP120 in the virus. With the conformational change, the viral envelope fuses with the host cell membrane. So you have the GP120, which is a glycoprotein within the virus. You have the GP41, which helps. So the first one mediates the virus attachment, and then the other one acts as the anchor. The first GP120 mediates the virus attachment, and the protein GP41 acts the anchor for the GP120 in the virus. Then, of course, once that the GP, you bring in the GP120, the GP41, that attachment to the CD4, the bivalent attachment to the CDB4, the CCR5, bring us about what we are talking about, conformational change, and it creates a pole, and of course the virus is able to move in. There is fusion occurs, and the virus is able to move into the cell. The most common drugs that prevent the virus from entering the CD4 cells are either maraviroc, envafolimab, and docosahexaene. Maraviroc targets a host protein. That is the one we are saying. So we are saying it is CCR5 tropic. It targets. So maraviroc targets the chemokine receptor CCR5. It is CCR5 tropic rather than a viral target. So this is what we had said. It goes for the target within the host. It doesn't go for the viral target. So that's a major difference between these drugs and the other ones we have looked at. Binding to this cell surface protein blocks human or HIV virus 1 attachment to the core receptor and prevents the virus from entering the CD4 cells. So you can see it goes, the drug goes for the chemokine receptor 5, binds it. There is some conformational change. Now the virus cannot bind, and once it can't bind, definitely there will not be fusion. The virus will not enter. It will not enter the host cells, and there will not be an infection. Maraviroc is a substrate of cytochrome P450, mainly cytochrome 3A4, and has clinically significant interaction with other drugs, including evavirenz and rifampicin. So that again is of importance, because any drug that is a cytochrome P450 inducer, especially the cytochrome 3A4 is one of the enzymes that metabolizes very many drugs. So it induces that enzyme, and therefore there will be drug-drug interaction. That is the drug. That is the maraviroc. That's a drug, maraviroc. This is the other drug we call docosahexaene. So you can see docosahexaene is a hydrocarbon with should have 22 carbon atoms. That is one. That is this in between here means CH2 repeated 20 times, and another, of course, CH2. So we can see it is actually an alcohol. Docosahexaene is an alcohol which has 22 carbon atoms, and then you have envafolimab. All this, of course, it's difficult to remember all this, but envafolimab has 36 amino acid. It is a polypeptide with about 36 amino acid. So those are the various structures of the three drugs that are responsible for blocking fusion. Docosahexaene is a saturated 22-carbon aliphatic alcohol, which exhibits antiviral activity against many lipid-enveloped viruses, including also the herpes simplex virus, HSV. So it not only will it have activity against HIV, also it has activity against herpes simplex virus. Docosahexaene speeds the healing of cold sores and fever blisters on the face or lips. It also relieves the accompanying symptoms, including tingling, pain, burning, and itching. Docosahexaene cannot, however, prevent cold sores or fever blisters from appearing. So it relieves the pain, it relieves the discomfort, but the cold sores will still appear. Then we have the envafolimab, which is a linear 36 amino acid synthetic peptide. So it has those many amino acids joined together through peptide bonds, with the N-terminus acylated and the C-terminus is a carboxyamide. It is because when you acylate it, remember the amino acids are highly ionized, but once you acetylate it, acetylate it, it's like you block it so that it has good activity. Because if you leave it open as an amino group, because you see, to form the peptide group, you must use either the carboxylic group or the amino group. So in fact, the terminal one, it means you are using a carboxylic group. The carboxylic group of the last amino acid is used to form the peptide group. So you have an amino group which is free. That free amino group can be ionized, or it can be influenced, or it can interact with other molecules. Therefore, you acetylate it so that it is blocked, or it is prevented it from undergoing a protonation, and therefore the molecule can be well absorbed. The other one undergoes is carboxylated. Remember, carboxylation, again, as we have said, it stabilizes. So the other staminas, if one is the amino one, the other one will be a carboxylate group. So you carboxylate that group. Remember, carboxyamides are stabilized by resonance and, of course, have higher lipid solubility. So that molecule has good activity and can be able to penetrate the membranes. It is composed of naturally occurring L-amino acid residues and is administered. It's administered parenterally. Of course, even when it's administered parenterally, still remember there are some membranes, lipid membranes. It has to cross. It has to cross lipid membranes. Of course, if it's in the blood, it must cross the lipid membranes to get into the cell and to get into the cell, so that it can be able to bind the receptors within the cell of the host. So it still requires to have lipid solubility, but because, of course, it has a lot of amino group, it has a lot of carboxylic groups, it, of course, still free, although you have carbamylated one of the C carboxylic group, and you have acetylated the terminal amino group. It still has a lot of amino groups and carboxyl group within itself, because you can see it has 6 amino acids, and I believe that is why it is difficult for it to be given orally. Of course, you also know that amino acids, when given orally, they can be denatured by the acid within the stomach, so that denaturization can occur. So you will give this drug parenterally. The drug product for injection is a white sterile lyophilized powder. So therefore, that is a drug. We are saying it is a peptide containing about 36 amino acids. Then the other one, so let us look at how it acts. The envafoetide it's a fusion inhibitor. It interferes with penetration of HIV-1 in the cells. It exhibits potent and selective inhibition of the membrane of the viral cells, and it is a peptide consisting of 36 amino acids. We've already said that. It is a synthetic peptide that mimics the HR2. The HR2 is a heptade repeat region. It is a heptade repeat region within the glycoprotein 41. And we did mention the glycoprotein 41 is what the glycoprotein 41 is what anchors the virus within the receptors. So it anchors the glycoprotein 120 within the receptor. It blocks the formation of a 6-helix bundle structure that is critical in the fusion of the HIV-1 viral to a CD4 positive T lymphocyte. So you can see it is actually, ultimately, as we have said, it will bind the CD4, it will bind the receptor, and in binding the receptor, it prevents the penetration of the virus into the host. Specifically, it binds the tryptophan-rich region of the GP41 protein, bind to that, and thus preventing the formation of an entry pore for the capsid of the HIV virus. Remember, the viron has a capsid, it's encapsulated, so it is preventing that from entering the host cell. So the envafoetide, this one binds a slightly different enzyme. This one binds this one is interfering with it's also interfering with the what we are calling, it's interfering with the GP41, GP120, GP41. The other one was interfering with the Maviloc goes for the CC, the chemotaxin 5 receptor. This also is having a slightly different mode of action, but ultimately it does the same. So we have said, let's look at it. It's a synthetic peptide, blocks the formation of this particular complex. Remember the other one, we said it goes straight for the chemotaxin receptor 5. This is going, so it blocks the formation of the 6 helix bundle structure that is critical in the fusion of the H1 viron to CD4 positive lymphocyte. Specifically, it binds the tryptophan-rich region of the GP41 protein. Efavirenz binds to GP41 and thus preventing the formation of an entry pore for the capsid of the H1 virus. Clinical application is used in combination with other antivirals and works against the variety of H1 virus variety, but it is not active against HIV-2. Injection site reactions, whereby you can have swelling, you can have redness, pain or discomfort, rash, bruising, and hardening of the skin. You can have nervous pain, numbness, burning or prickling feeling of your skin that lasts for almost 6 months. Others include diarrhea, fatigue, and nausea. So you can still see these drugs do have a lot of toxicity. So that is the one which is binding or is forming, preventing deformation. By selecting a particular part, it prevents the formation of which this compound we are calling the 6 helix bundle structure that is critical in the fusion of the H1 viron to a CD4 positive T lymphocyte. So we had, and with doing so, as we have said, it blocks the entry of the virus. Then we have the Maraviro, which we are saying this one is specific for the chemotaxin C chemotaxin receptor 5, and it will inhibit, it will bind that portion. Again, this will bind this particular portion of the host. The other one we have said it is doing a little bit, it is binding a little bit different. It's preventing the formation of a particular complex, which is important in the fusion. This goes for a specific enzyme. It selectively binds to the human chemokine receptor CCR5, which is present on the cell membrane. So it goes for this particular receptor within the cell membrane. This binding prevents interaction of HIV-1 with the chemokine receptor 5 tropic HIV-1. When you say CCR5 tropic, it means this particular HIV-1 is going specifically for the CCR5. The other receptors, as we had said, you can have them going for the CD4, as we have seen for the efavirenz. You can have them going for the CXCR4, or you can have them going for what we call geotropic. So there can be the CCR5 tropic, you can have CD4 tropic, or you can have also geotropic, whereby the drug is binding, can bind 2 different sites, can bind the CCR5 and can also bind the CD4, or it can bind the CXCR4 receptor within the host cell. What are the clinical applications? It is used with other medications to treat CCR5 tropic HIV type 1. So you treat the HIV type 1, which specifically binds the CCR5, because we are saying there are those viruses which will bind the CCR5, there are those which will bind the CD4. Maviloc is generally well tolerated with the incidence of diarrhea, nausea, headache, and fatigue similar or less to that of the placebo. The most common adverse reactions are upper respiratory tract infection, cough, pyrexia, and so on. Those are things that you've done a lot in pharmacology. So those are the 3 drugs that are used as fusion inhibitors for specifically the HIV and AIDS viruses. Not, of course, we have said docosahexaene can also be used for other viruses, but it can also have some activity, the HIV and AIDS entry into the host. And we are saying, of course, their mode of action is going for the host target, is going for the receptors which are within the host. And once it goes for the receptors within the host, it will prevent the virus from accessing the host cells. It will not bind the host cells. Once it doesn't bind the host cells, that means then there is no fusion, there is no entry, and therefore you will reduce the infectivity. There will the patient, the host cells will not be infected, and therefore you will control the HIV and AIDS. Then we have the metabolism. This is a structure. I had given the various structures, I believe. So this is a structure of Maraviroc, and it can undergo mainly hydroxylation. Main mode of metabolism is hydroxylation. So you have the Maraviroc there, 21%. It can undergo 1s, 2s, 2-hydroxylation. So if you look at this structure here, this is the fluorine here. This here and this position here. So this already at that point is a chiral center. Already this is a chiral center there. And then it's undergoing hydroxylation at that position. And the resultant metabolite also has stereochemistry, and the resultant compound is what we're calling 1s, 2s, 2-hydroxy Maraviroc. So we are only saying when the hydroxyl group comes in, it carries, you can see it is alpha orientation. I think it's beta orientation. It carries a certain orientation, so the metabolism is stereospecific. So you can't get, and that is the one formation of the 1s, 2s hydroxymaraviroc is the one which is a major, used as a major metabolite. It can also undergo hydroxylation. You can see this methyl group there. Can also undergo. Remember, anytime you have alkyl groups are susceptible to to oxidative hydroxylation, so it can undergo oxidation at that particular point, and of course that gives us the hydroxymethyl maraviroc, and of course that's just 1%. It can also undergo again hydroxylation at position. You can remember that was position 1, position 2, that's position 3. So it is undergoing hydroxylation at position 3, and still stereospecificity to give us the S metabolite. So it is a 1s, 3s hydroxymaraviroc, and it can also go they are very low amounts of metabolites. Can also undergo metabolism again at position number 3, 1s, but this time the 3 is an R. It's just a change of the configuration, change of the orientation of the hydroxyl group. This one is 3s, this one is 3r. So it gives us 1s, 3r, 3-hydroxy maraviroc. So those, of course, these are enantiomer. Then, of course, it can also, this one was 1s, 2s. Again, it can also undergo again just 1s, but you can see this is much lower. The 1R, 2R, much lower than 1S. That's why we say the dominant metabolic pathway is that which gives us the 1S, 2S hydroxy metabolite. Can also go to a very small extent, again 1%, to give us the 1R, 2R. Of course, these again are enantiomer. So as we can see, the main routes of metabolism is hydroxylation of both positions 2 and position 3, either to give us the S or R isomer, with the S isomer being the major metabolite, with the S isomer being the major metabolite. That we have looked at that. So those are the 3 fusion inhibitors: docosahexaene, envavirtide, and maraviroc are the 3 inhibitors which can be used for prevention of fusion as fusion inhibitors for the HIV-1 virus. Then we move on to the next class, and the next class is the integrase inhibitors. And under the integrase inhibitors, we have dolutegravir, vitegravir, lautegravir, and cabotegravir. Cabotegravir is a derivative of dolutegravir. If you look at it, or it is an analog rather of dolutegravir. If you look at this ring here, it's a morpholin ring, and you can see that's a 6-membered ring, as opposed to this one here, which is a 5-membered ring. That, I think, is the main difference. And of course, this one has a methyl substituent at that position. So this has a methyl substituent there. But I think if you look at the structure, look at that, this ring, first ring there, That one is the same as this one there. And then join to an NH, join to an NH, to a double bond O. Then it's of course also the substitution there. Here differs a bit. Then here, so join to, then it's joined to this, which has a double bond O and OH, which also has a double bond OH. So that is still the same. And then it's joined to the other ring there, which is completely the same. So the only ring which is different is this terminal ring there, where this is a 5-membered heterocyclic ring, and that's a 6-membered heterocyclic ring. That is a major difference, and that's why we are saying the carbotegrapher is an analog of dolutegrapher, with only one difference, where the 6-membered ring of dolutegrapher has been replaced with a methylated 5-membered ring with retention of activity. Again, you can see when you look at these drugs, you can actually see that, yes, they might have some portions that look like alike. Like, of course, you can see this is a tricyclic ring, this is a bicyclic ring, this doesn't even have a bicyclic ring or a tricyclic ring. So we can see there is a lot of structural differences. There's a lot of structural differences in these compounds, and they still do have the activity that is expected. That's why it is a bit difficult to do SAR, structure activity relationship, because there's a lot of structural differences within these compounds, but they are still able to bind the respective receptor. So integrase inhibitors, and we are looking at, this is now another enzyme. Integrase is a specific enzyme which is found within the virus, and it is used to integrate to incorporate the viral DNA into the host genome or into the host DNA, and then after that, the host DNA with the viral DNA now synthesizes the viral proteins, structural proteins, synthesizes the viral functional proteins. It also synthesizes the viral RNA, and of course, all these then come together in a form of assembly and form the virus. So the integrase enzyme is very, very important, because you require it to incorporate, to integrate, to incorporate the complementary or the viral DNA into the host genome. So once you block it, and of course it is a unique enzyme within the virus, once you block it, then integration will not occur, and you will stop again the development or the propagation of the virus, or its multiplication, replication, and hence you will be able to control. Because remember, we said you really are not able to kill all of them. You can only control their concentration, their numbers, and once you control their numbers, of course, then you can be able to give the person a quality life, as long as they're continuously on the drugs. Of course, now there is the information that we are getting drugs that are able to cure HIV, but we're still waiting. Integrase is a viral enzyme that catalyzes both the 3' processing of the viral DNA in the cytoplasm and the insertion of the viral DNA into the chromosomal DNA in the nucleus. Once the viral DNA, which we are calling the complementary DNA, is formed, there is cutting off of two nucleotides are removed from that complementary DNA before it is integrated into the host DNA. That's what we are calling the processing of the viral DNA. And then at the 3', and then after that, it's incorporated. And once it's incorporated, then, as we have said, the virus takes command of the cell, and it produces its own proteins, produces its own nucleic acids, and then of course therefore some of the cells, of course, will die. And after that, of course, it gets out, invades other cells, and the process continues. Integrase inhibitors are a class of antiviral drugs designed to block the action of the integrase enzyme. Since integration is a vital step in retroviral replication, blocking it can further halt the spread of the virus. So you can see what we are halting is the spreading. We are halting the spreading. And therefore, once we halt the spreading, we will halt the number of host cells that are infected. We'll lower the load. We will lower the viral load. And of course, that is what you require for the person not even to display the symptoms of HIV and AIDS. Mechanism of action. So we have mentioned various drugs. We have one of them as raltegravir, inhibits the activity of HIV-1 integrase, which impedes the insertion of HIV-1 DNA into the host cell genome. It inhibits integration, and the results are consistent with inhibition of the third step of the integration process, which we call the strand transfer. So we already have mentioned that. So we can note that after reverse transcription, integrase protein assembles with the viral DNA to form a stable complex, the pre-integration complex, PIC, and enters the host cell. This is also what we are calling the complementary DNA. But you can see to contain a bit of the RNA, to contain, of course, quite a lot of the DNA. Of course, this has been synthesized by the reverse transcriptase, which is able to convert, of course, the RNA of the virus into the DNA. Integrase mediates the integration of the complementary DNA into the host genome in a two-step process. Two nucleotides are excised from the 3' ends of the viral DNA. Covalent insertion of the HIV viral DNA to the host chromosome occurs. This we have already discussed. The integrase inhibitor, raltegravir, interacts with divalent metals within the active site of the HIV-1 integrase. In other words, these drugs, most of them are chelating agents. They are chelating agents. They will chelate the metal ions around the integrase enzyme, and the metal ions are necessary to promote or to enhance the integration of the complementary DNA to the host DNA. This interaction inhibits the insertion of the viral DNA into the host chromosome, or what we are calling the strand transfer process. Vitegravir is also a specific inhibitor of the strand step of the HIV integration. So even it will chelate, and it will also inhibit. It will chelate the ions, and at the same time, we have also said it will bind the enzyme and inhibit it, and therefore no activity. Dolutegravir is the only second generation integrase inhibitor. So we are also going to look at the dolutegravir. So this is what we are saying. So you find, as we have said, within the cytoplasm, there is formation of the pre-integration complex, or also what we are referring to as the complementary DNA. And of course, we said last time, it is after it is formed as a single strand, it undergoes circularization, and it's bent circularization to form so that it looks, you can see it looks like a double helix. So that it looks like a double helix, then it gets inside, it gets inside, and as it gets inside here, you can see it's supposed to use the integrase enzyme. So it is supposed to use the integrase enzyme to be integrated into the host nucleus, and this is where the integrase inhibitor is working. So the integrase inhibitor, that is where it's working. It's inhibiting the integrase enzyme, and therefore there is no integration. And once there is no integration, then the virus is not able to make its own proteins. It's not able to make its own messenger RNAs. It's not able to make its making of proteins is of course through its own messenger RNAs. It's not able to make structural proteins. It's not able to make the functional proteins. It's not able to replicate itself, and therefore there will not be. Therefore its propagation will be halted. Cabotegravir also, so all of them, of course, have the same mechanism of actions. Perhaps they will differ in their structure, and perhaps differ, of course, in their level of protein binding, differ in their mode of administration, differ in their duration of action, but basically they have the same mode of action. So cabotegravir is a potent also integrase strand transfer inhibitor and a structural analog, as we have said, of dolutegravir, and we have looked at that. It's unique. It has unique physical, chemical, and pharmacokinetic properties that has allowed for its formulation and delivery, both as an oral tablet for daily administration. So it can be formulated in a tablet. I believe these are things that, again, you do in pharmaceutics. And it can also be formulated as a long-acting nanosuspension for monthly to quarterly intramuscular injection. In other words, very, very low concentrations, nano suspension, and it can be given quarterly, monthly or quarterly. This would be of a lot of help, because that means the patient will not have to take the drugs every day. They can be injected monthly, or they can be injected quarterly, and the drug will have activity. So that is a very good characteristic of cabotegravir, where you can either give it as an injection or you can give it as an oral tablet. Give it as an injection, it can see it has a depot activity, and once it has a depot activity, depot doesn't mean it's going into the tissues. Depot means it has a long duration, it has a long activity. It's long activity. It acts as a reservoir, whereby it's very slowly released, acts as a depot, as a reservoir, slowly released, and has a very long duration of activity. It's unlikely to be impacted by the cytochrome P450 metabolic pathway. Again, very important, because we know especially the cytochrome 3A4 are notorious, or the cytochrome P450 enzyme are notorious for drug interaction. Cabotegravir has a low propensity to cause or low susceptibility to drug interaction. So that again is an advantage. As I have said, the mode of action is the same. What will differ is in the formulation, whereby once you differ in the formulation, you can improve on the patient's compliance. And again, you can see these drugs, unlike the ones we were looking at before, they do not have drug interactions, because they have no influence on the cytochrome P450 enzyme. Metabolism of cabotegravir. This is our cabotegravir. And one of the things that can happen, you can see cabotegravir already has a hydroxyl group there, so it does not require to undergo primary or phase 1 metabolism. It already has a hydroxyl group, it already has a hydroxyl functional group, so it can undergo direct glucuronic conjugation. This is just glucuronic acid. Glucuronic conjugation, of course, catalyzed by glucuronic transferase, and of course there is glucuronic conjugation of that to give that glucuronide. And once you have now that cabotegravir, glucuronide has high water solubility and will be readily removed from the body. And the other one is just the same. It has already undergone glucuronic conjugation, and here all that has happened is there is reduction. So here this is a reduction process whereby the carboxylic acid has been reduced to the alcohol. But this compound, the major metabolite is the M1 metabolite, but you can have a bit of this metabolite. And as I have said, this is just a process where it is coming from here, kind of to there, where this glucuronide, the carboxylic group of the glucuronic acid has been reduced to an alcohol. But the compound still has very good water solubility, and therefore will be removed from the body. So that is cabotegravir. Just 1 minute. Sorry about that. So the other drug which we have said is an analog of cabotegravir is the dolutegravir, and it is highly metabolized through 3 main pathways, and it forms the metabolites are not long lived. So of course, once you metabolize, more often than not, they high water solubility and they are excreted. So again, you can have glucuronidation, of course, using uridine glucuronide transferase, There can be different ones. You can also have carbon oxidation or hydroxylation, again catalyzed by cytochrome 3A4. So unlike what we did mention of carbotegrava, there was no oxidation. There is also sequential oxidative defluorination and glutathione conjugation. So we are talking about, if you look at the structure of dolutegrava, you saw it has some fluorines. So those fluorines can undergo dehalogenation or defluorination, and of course also this compound can also undergo glutathione conjugation. Remember, there are several ways of detoxifying. One of the ways of detoxifying highly toxic metabolites is through glutathione conjugation. And remember, glutathione has 3 amino acids, and that's obvious in that you can also, this compound can undergo glutathione conjugation. And as it undergoes the sequential oxidation, it also undergoes the glutathione conjugation. The main metabolite found in the blood plasma is the ether glucuronide form, and its chemical properties disrupt its ability to bind metal ions, therefore it is inactive. Remember, we did mention that these drugs, being integrase inhibitors, they kill it, the bivalent ions, they kill it, the metal ions, and in killing the metal ions, they prevent the enzyme, they kill it, the metal ions, and therefore prevent the enzyme from acting or from integrating, for being able, the integrase enzyme, from being able to integrate the complementary DNA into the genome, into the host genome. So there is those ions, and quite a number of enzymes do act in the presence of ions. So once those ions are chelated, then this enzyme is not able to act. So we are therefore saying you can have the ether glucuronide, dolutegrava, you can have the hydroxylated, this should be hydroxylated form of dolutegrava. Remember, the hydroxylated form is where you have having the cytochrome P3A4 oxidizing a carbon, or you can have hydrolyzed, where it's hydrolyzed. This one, there are no specific enzymes that have been mentioned, or you can have defluorination and glutathione conjugation form. So you can have the first defluorination, or you have 2 fluorines adjacent to each other. So either of them can undergo defluorination. And when the first one undergoes defluorination, you get a certain metabolite, and then the other one can also undergo. But at any one time, you have one of the fluorines present. So the metabolites, I think, is like this now. So this is our drug. I put it upside down so that we can be able to compare it with the products that we are getting here. So I put it upside down. So you can see that those fluorines there, that, and here ether. So we are looking at this hydroxyl group at this point. So it already has that hydroxyl group, and that hydroxyl group is the one which is undergoing glucuronic conjugation, uridine glucuronide transferase to give us the ether glucuronide, which we said is a major metabolite. Then you can undergo hydroxylation catalyzed by cytochrome 3A4, and you can see this group here. That's why we called it carbon oxidation. That point there undergoes hydroxylation catalyzed by cytochrome P450, cytochrome 3A4, and that undergoes oxidation, and that is what we are calling, that the hydroxylation, and that's what we are calling our hydroxylated hydroxylated drug. And then also you can have it hydrolyzed. This is the one I've said we do not have the specific enzyme which bring about these hydrolysis. And you can see again, if you look at this compound, the dolutegravir, we are looking at it at this point again. You can see this the C double bond ONH2, C double bond. So that cleavage at that particular point. So it's not a amide hydrolysis. It's a cleavage at that particular point. And once the cleavage occurs at that particular point, or it's hydrolyzed at that point, then it gives us a hydrolyzed dolutegravir. Then, as I had said, you can also have your dolutegravir. This is your dolutegravir, that fluorine there, another fluorine. They're not completely adjacent. They're separated with one carbon atom. You have one fluorine there, have the other fluorine there. So in this particular one, you can have what we're calling the oxidative defluorination. So it is removed with addition of a hydroxyl group, and that is why we are calling it oxidative defluorination. And you can see our other fluorine still remains. Then at the position where we had, at this position here, then you got the glucuronic conjugation. You can see this cysteine. Remember, you drop off the glycine, you drop off the glutamic acid, and you're left with cysteine. So you can see this is the glutathione conjugation at that particular position. So you have oxidative dehalogenation, and you can, as we have said, everything else remains intact, and you have the fluorine, one fluorine at that position remaining. The other one that can happen is just now, instead of this fluorine here being the one which is undergoing oxidative dehalogenation, this fluorine now down here. Sorry, I left one. This fluorine undergoes is the one which undergoes the oxidative dehalogenation. So this position here becomes an OH. Has been left out by mistake, and of course you have your fluorine followed, of course, by glutathione conjugation. So those are the main metabolic pathways of the dolutegravir, whereby the ether glucuronide, we have said, is a major metabolite. So clinical applications of integrase inhibitors, and we have already said they will be used together with other drugs. The integrase inhibitors will be used together with other drugs in combination, that is following the guidelines for heart, combination with other antiretroviral drugs for the management of HIV and AIDS. And the transition from non-nucleotide reverse transcriptase inhibitor added combination with PI-centered regimens to the integrase inhibitors centered therapies is actually happening. And I believe when you went out, I hope you did find out some of the combinations whereby, because we remember we say the PIs, and we're going to look at the PIs. The PIs do have a problem because of enzyme induction and therefore a lot of drug toxicity. So depending again on the condition, on the type of patient, on the needs, specific needs of the patient, depending on whether they have other conditions, whether they have opportunistic diseases, which other drugs are they using. You must assess the patient very well so that you know which is the best, which is a unique combination that best fits that patient. And that's why we are saying the integrase inhibitors are actually now in use in replacing either the PI or replacing or being part of the heart combination, because they have been found also to be highly effective and also to have lower toxicity. So the transition from non-nucleotide reverse transcriptase inhibitors and PI-centered regimens to integrase inhibitor-centered therapies was due to the virologic efficacy. So they have got good efficacy, superior safety, tolerability profiles, low number of drug interactions, no known cytochrome 3A4 drug interactions with the integrase inhibitors. So all those integrase inhibitors, we do not have any known drug interactions, or we have no cytochrome 3A4 drug interactions that have been registered. In other words, even if they're happening, because we have seen like the dolutegravir is metabolized by cytochrome 3A4, but we are saying very minimal, if any, and not detectable. And once you have no detectable, they are non-detectable, then that is a safe ground. And as compared to the other drugs, where we have said there is a lot of drug interactions because they are mainly metabolized by the cytochrome 3A4, the mixed oxidases, or the mixed function oxidases, or the cytochrome P450 enzyme. Furthermore, The integrase inhibitors containing therapy showed improved efficacy with regard to viral suppression compared to ritonavir boosted darunavir therapy. We are going to look at ritonavir. Of course, this ritonavir is a PPI. So we are saying that this were found to even have better activity. That's where we have said virologic efficacy. They have a higher virologic efficacy, and therefore, remember, I had said the turnover is just mainly used as a booster. We're going to look at it. So, and once you get whether it's a new drug and it has better efficacy, it has lower toxicity, and of course, it has lower toxicity, there is always a need to revise. There is always the need to revise the regimens you have or the drugs that you are using for the management of a condition. If you come up with a drug that is better placed than the already existing ones. And the integrase inhibitors have been found to have good activity. And I believe when you go out there, you will find that you do have lopitagravir and even lopitagravir being added to the heart combination for better activity. So those are integrase inhibitors. The other one, the other very important class is a protease inhibitor. Protease inhibitors. And again, when we look at these drugs, we have quite a number of them. And of importance, again, is to look at the cervix. Cervix can tell you that all of them belong to the same class. Lopinavir, amprinavir, saquanavir, neofrinavir, indinavir, atazanavir, ritonavir. All of them, we are saying they have a hydroxyethylene bond. All of them have a hydroxyethylene bond. We're going to look at it. So we have that is a structure of saquanavir, as a structure of ritonavir, structure of indinavir, structure of neofrinavir. Again, when you look at them, they are bulky, but we cannot really say they have a lot of structural similarity. They do have, they are quite structurally different, but they are able to bind this enzyme or to inhibit this enzyme, which we are calling the protease enzyme. So again, that's the same. The protease, this is the protease enzyme. So this is almost the last stage, whereby we have said after the HIV, after the complementary DNA has been incorporated into the host DNA, it starts synthesizing structural enzymes, starts synthesizing the functional enzyme, but they are synthesized as a provirus, as a huge virus, as a huge molecule. So the role of the protease enzymes is to cleave them, is to cut them into the right size. If you want the integrase enzyme, it is cut into its right size, of course, with the amino acids being in the right sequence. If you want the other enzyme, it is cut into the right size. If you want, so the role of the protease enzymes is to be able to cut the different proteins, the different enzymes into their right sizes so that they can be functional. Otherwise, if you don't block the protease enzyme, then that means you will have the provirus, or you will have the very large proteins which has not been chopped into the right size, and therefore it will not be functional. So protease cleave the viral polyproteins into individual functional HIV proteins and enzymes. It cleaves them, as we have said, into functional HIV, functional like the enzymes, functional individual functional HIV proteins. In other words, they can be able to do what they are supposed to do. The enzyme, they have proteins that are within the virus, and they can perform their rightful function, and even the enzyme. The various structural components then are able to produce a mature HIV virus, which is capable of infecting another cell. Remember, the assembly. The assembly comes after you have formation of the proteins, the functional proteins, the structural proteins, and even the nucleic acid, then you have this assembly. If you do not have any of those proteins or even enzymes formed, then even if you have an assembly, the virus will be defective and it will not be able to infect other cells. The protease inhibitors bind the protease enzyme, preventing the cleavage and inhibiting the assembly of the new HIV. They act at a late step of the viral cycle. They are effective against both newly and chronically infected cells. Hence, HIV produces non-infectious viral progeny because the enzymes are fraudulent. The enzymes are defective. The proteins that you have within that virus are also defective and they cannot function. When proteins, you have several proteins. Remember, we have several enzymes. Remember, we talked about the DNA polymerase enzyme, the transcriptase enzyme. All those must be synthesized and be part of this virus before it can be assembled and then released. When protease and reverse transcriptase inhibitors are used together, the antiviral activity is enhanced and viral resistance is slower to develop. So again, you can use protease and the reverse transcriptase inhibitors. We have mentioned quite a number, the reverse transcriptase inhibitors, and you can put them together. And once you do so, then you will have some better activity. Because they will be synergistic because their mode of actions are different. So I had said about this hydromethyl structure or ethylene structure there, hydroethylene structure. You can see, so that is the only bit within all these drugs that has been found to be a constant. So that is the only portion within these drugs that has been found to be a constant. And I think that pharmacophore, as small as it is important for the activity of these drugs. For Saquaniva, it's well tolerated following oral administration. Absorption is poor but is increased with a fatty meal. Drug does not distribute this to a CSF. It is highly bound to plasma proteins, extensively metabolized by the fast pass effect, and no wonder it has poor oral bioavailability, has low bioavailability, which is slightly huger. For the soft capsule, you have two types of capsule, the soft and the hard capsule. It exerts a synergistic antiviral effect when combined with reverse transcriptase inhibitors such as zidovudine and DDC. I think this is didanosine. So if you mix them together, then you can have synergistic activity. Of course, that is because they have different modes of action, and of course, they are synergistic. They are affecting different enzymes within the same path. The pathways might be different, but the overall pathway is a pathway to help in the synthesis of the proteins of the enzyme and of the nucleic acids of the virus. So once you hit at different pathways within the synthesis of the virus or the formation of the virus, then you will have definitely synergism. HIV-1 resistance to Saquaniva and other HIV is less stringent and less frequent than resistance to the RT inhibitor. So the resistance is not as bad as that for the RT inhibitors. Again, when we mix them, then will give us good activity. Cross resistance between different HIV PIs appears to be common and additive. Again, that is a drawback. Once you have resistance to one, then there is no need of using any other. You will have to change the regimen. Using combination of inhibitors from this class would not constitute rational prescribing. In other words, you cannot put two inhibitors, but we do know we can use ritonavir, as we have said, but in low concentration because it has been found to block the cytochrome 3A4. And because it can block the cytochrome 3A4, then it becomes a pharmacokinetic enhancer. But you cannot take two, like Indiniva, Saquaniva, you put them together. It does not have any added advantage because these two drugs are not synergistic. They are acting on the same enzyme again, once you develop resistance to one, you develop resistance to the other. So it is not advisable. But as I have said, you can use the turnover at much, much lower concentrations, not at the concentrations of for treating HIV, but at the lower concentrations where it is used as a booster or an enhancer. The drug can be used in combination with at least 2 other antiretroviral drugs to minimize resistance. Doses for the hard capsule. So we have the Antivirals, which is a hard capsule, and Photovins, which is a soft capsule. I believe now, I don't know, there must be other perhaps. So the one which is the hard capsule, we call it Antivirals. The one which is the soft capsule is Photovins. But I believe these are trade names for certain companies. And of course, we have others. I think now we have even some of the local companies producing these drugs. So that's our structure. We have already mentioned its mechanism of action. It's to inhibit proteins, thus preventing post-translational formation of viral proteins. It contains a hydroxyethylamine. So that is the group that we talked about. This hydroxyl. This is the hydroxyl ethyl 1,2-amine. So the whole of this portion here is what we are looking at. Portion there. So it contains the hydroxyethylamine more than the phenylalanine chlorine sessile bond present in the normal substrate for HIV proteins. It means this group, the phenylalanine, I believe, I hope the PHE stands for phenylalanine. I will confirm PHE pro. So this group, this combination of amino acid is what is found in the normal HIV proteins. So this combination is what is found in the HIV proteins, and this is readily cleaved. This is readily broken. It contains the hydroxyethylamine moiety and then the phenylchlorine sessile bond present in the normal substrate for the HIV proteins. So this is where the cleavage is occurring. This is what you have, and therefore the cleavage is very easy. So this drug contains this more stable group. So once this drug binds the protease enzyme cannot cleave it. Protease enzyme cannot cleave it. So this will bind the protease enzyme, and the protease enzyme will be completely inhibited, and it will not be able to cleave this particular weak bond. So that's what we are saying, that the substrate has a weak bond, which is readily cleaved, but this drug has that, almost all of them has that group, and that group, when it binds, definitely it is not cleavable, and therefore will inhibit the protease enzyme. And once it inhibits the protease enzyme, it is not available. It is bound, it is inhibited, it is not available to cleave the provirus or the huge viral protein, and therefore into the functional proteins that you require for the virus. So it is used in the treatment of advanced HIV infection in selected patients. So again, you must know which patients you are dealing with, because as we have said, these drugs have the major problem of enzyme induction. So you must have selected patients, you must select them well, because it depends on other infections they have, other drugs they are taking, and so on. Then you have the ritonavir, and again, I believe you can get that, see whether we can still get that group. We have the hydroxy. Does this one have that group? Ritonavir. It has the hydroxyethylene. This one has the hydroxyethylene, but not exactly the amine. The amine has been separated with this carbon, but it has the hydroxyethylene. Even this one, as we had said, has the hydroxy there. Hydroxyethylene, this one also has the hydroxyethylene amine. So the leofenavir has hydroxyamine, there's hydroxyethylene amine. Lopinavir has hydroxyethylene. It doesn't have an amine. So the amine doesn't seem to be in all of them, but we have found it. We have seen it is there in sequaniver, hydroxy. We found hydroxyethylene amine. It's not there in ritonavir. It's not there in the amine group is not there in indiniva, but it's there also here. But although it's separated with one carbon atom, at least this one you can see it's nowhere. Here you can see it's separated. It's separated by one carbon, but there's an amino group. Indiniva doesn't have the amino group at all. But the ethylene, the hydroxyethylene, is in all of them. The hydroxyethylene is in all of them, and we are saying that gives a stable bond. It gives a stable bond, and that stable bond does not allow for hydrolysis, and therefore will permanently, or will inhibit. Because these drugs do inhibit reversibly. They don't, so they usually inhibit reversibly. But as they bind, they will bind, and of course prevent the formation of the virus. Then we have the ritonavir, or it is a much larger. It's larger than sequaniver, but displays has been found to have better bioavailability, and you see why it has a better bioavailability. It's because it is a potent inhibitor of cytochrome 3A4. So it has better bioavailability because it's a potent inhibitor of cytochrome 3A4. It will shut down its own metabolism. So the others are undergoing a lot of fast-pass metabolism in the intestines, in the liver, and they're inducing also their own metabolism. But ritonavir is a cytochrome 3A4 inhibitor. So it shuts down its own metabolism. Number two, also, within, it's also able to shut down the efflux. Within the intestine, you find that there is a glycoprotein pump, which is responsible for efflux. Well, as the PIs are absorbed, there is a glycoprotein pump responsible for efflux of the drug back into the intestines. So you find that ritonavir also blocks that efflux. Remember, efflux is usually catalyzed by an enzyme, so it blocks that pump. Even at the CD4, as this drug gets in, at the CD4, there is also another. You find that even at the CD4, there is another efflux pump there, which pushes the drug out. See, so at the CD4, there's also another efflux which pushes the drug out. Again, ritonavir blocks that pump and hence is able to concentrate the ritonavir drug within the virus. So, and that is why we are calling it a pharmacokinetic booster. It's a pharmacokinetic booster or a booster because it blocks the metabolism, it improves on the absorption, and therefore of itself and even other protease inhibitors, and therefore you give it in low concentration to increase the concentration of the other PIs, because we did say there's no added advantage of doing 2 PIs for management, but you can give it small concentrations to act as a booster and therefore block the cytochrome 3A4, block also the efflux pump, so that the PI drugs are concentrated within the virus and therefore being able to get into the virus and bind the protease enzyme and hence stop the cleaving or stop the propagation of this particular virus. So we use as a booster or pharmacokinetic enhancer at low concentrations. You can see a low concentration in combination with other PIs. So we have said there is a glycoprotein pump. It decreases that efflux. The pig glycoprotein pump is responsible. It's found in the intestine, responsible for efflux. Also in the intestines, and the liver, it will decrease fast-pass metabolism. It will also decrease efflux from the CD4 cells. And once that happens, the PIs will be more concentrated and will reach the necessary concentration to block the protease enzyme. Then we have the indiniva, was designed based on sequaniver. it has better oral bioavailability, it has less binding to the plasma proteins. So those are the PIs, and of course, out of the PIs, we understand their mode of action. Very important, acting at the late stage, blocking the protease enzyme. The proteins cannot help us in forming the proper size, the proper sequence and size of the enzymes and the proteins required for the functioning of the virus. Then you also have, so I think those are the ones I have. I don't know whether you did more, but I think those will be representative. Then also you have, we have done Sequaniva, sorry. Then you also have, I think we have finished the PIs. Then you have the miscellaneous agents, and one of the miscellaneous agents is foscarnet. You can see it has a very, very simple structure. Very, very simple structure indeed. And the mechanism of action, it directly inhibits the DNA and RNA polymerase and viral invariance. Viral, that's a transcriptase enzyme, does not require phosphorylation for antiviral activity. Remember, for most of the drugs that we looked at, most of the drugs, especially the nucleotide reverse transcriptase inhibitors, they had to undergo phosphorylation. So this it's like already it's phosphorated in it. It's a sodium salt it's actually a sodium phosphate salt. So because you can see this carboxylic group there, we have a carboxylic group there, and we have a phosphate there, PO3 there, and carboxylic group there. So so we are saying it does not require phosphorylation. It acts the way it is. It goes directly for the DNA and RNA polymerase. It goes for the viral transcriptase enzyme. It does not require phosphorylation for activity. It blocks the pyrophosphate binding site. Remember, whenever the nucleotides are binding the DNA polymerase, they come as triphosphates. They always come as triphosphates. But when you look at them within the DNA, you find they are monophosphate. So you must be cleaving the DNA, the DNA polymerase, as it joins these nucleotides, it must also be cleaving. So it does have a site to be able to cleave the pyrophosphate. Pyrophosphate is the two phosphates together. So we are saying that this drug can bind that pyrophosphate site within the DNA, within the DNA polymerase, so that the DNA polymerase is not able to cleave. And therefore, once it's not able to cleave the triphosphate nucleotide, then it cannot be able to join it onto the growing nucleic acid. So that's what we are saying, that this drug that's what foscarnet blocks the pyrophosphate binding site, preventing cleavage of the pyrophosphate from the deoxynucleotide triphosphate. Again, we are reminded all of them before they join, before they are picked up by the DNA polymerase, they must be in the triphosphate. But when they join with loss of pyrophosphate. So the DNA polymerase must also be having a site where it's able to cleave the triphosphate, to lose the pyrophosphate, and have the monophosphate continue added onto the growing nucleic acid for continuous growth until you get the right size that you have. So that's why we are saying that it will block the pyrophosphate binding site, preventing cleavage of the pyrophosphate from deoxynucleotide triphosphate. And remember, all these enzymes, be it the DNA, RNA polymerase, or even the transcriptase enzyme, you require the triphosphates, and therefore it blocks that site in all of those enzymes, preventing them to add those groups, and therefore block the growing either of the RNA or the DNA, and so on. Viral DNA polymerase is inhibited at foscarnet concentration more than those required to inhibit cellular DNA polymerase. So this again gives us a bit of selectivity. It can block the host DNA polymerase, but you require very low concentrations to block the viral DNA. So therefore, the concentration you give for this drug is not enough to block the DNA. And if it does block the the cellular or the host DNA to be to a very, very low, to be a very low extent. And therefore, we are using concentration as a method of selective toxicity. Some of its adverse effects can be hypocalcemia, hypomagnesia are common, neurotoxicity and nephrotoxicity. It is an alternative drug for herpes simplex virus infections, especially those which are acyclovir resistant and immunocompromised patients. You can also use it for CMV or cytomegalovirus, retinitis, or ganciclovir resistant. So remember, I didn't mention ganciclovir resistant immunocompromised patients. So it has an advantage that you can use it in some of the patients whereby you have acyclovir and ganciclovir resistance. So mainly we are using it for the DNA viruses, But we are saying it blocks the DNA polymerase, the transcriptase enzyme, and it does so because it blocks the site within these enzymes where when the triphosphate binds, then it's cleaved, so that after cleavage, it is added on the growing nucleic acid with loss of the pyrophosphate. And I think that was my last slide.